This week we're going to tackle the problem of diabetes mellitus. This can be found in Chapter 5 of the 3rd edition of your textbook. In this lecture, we're going to discuss diabetes mellitus, and we're going to look specifically at the two types, 1 and 2. So one of the goals is to distinguish the difference between type 1 and type 2, and then the focus will be type 2 because it is primarily of a dietary and lifestyle origin. Much like cardiovascular disease, type 2 diabetes is greatly influenced by the quantity and the quality of our food, and this can increase the risk of type 2 diabetes, especially if that quality is poor and the quantity is great, thus leading to obesity. So you will learn in this lecture that obesity is very much tied to type 2 diabetes. What we learned in the previous chapter is the extent to which the sweetening of our food supply has led to the obesity epidemic. And what we're going to see in this chapter is how the obesity epidemic tied to the sweetening of our diet, whether it be fluids, the drinks that we take, the high-density caloric foods that we feed our children and ourselves, as well as the French fries and the processing of our food supply with high caloric density foods has led to the obesity crisis and to the type 2 diabetes epidemic that is changing the fabric of our society. The growth of diabetes mellitus in the United States is concerning. Between 1980 and 2012, type 2 diabetes specifically rose 420% over the 32 years. A total of 147.2 million Americans have diabetes or are at risk of being diabetic. In that way, they are pre-diabetic. This represents about 50.3% of the U.S. population who are either diabetic or at risk of being diabetic. Approximately 34.5% of U.S. adults are pre-diabetic specifically. That's 112 million American adults. The prevalence in childhood is also concerning. We can see significant rises there. Specifically, it's the American Indians that are the most vulnerable to type 2 diabetes. The cost to manage type 2 diabetes is even more impressive. In 2007, it cost $174 billion in direct and indirect costs. By 2012, the cost reached $245 billion, and by 2021, it rose again to $327 billion. Type 2 diabetes rises, in fact, with the obesity prevalence, and this is because essentially 80 to 90% of people with type 2 diabetes are obese, and we also know that 90 to 95% of all new diabetic cases are type 2 diabetes. Now let's take a look at type 1 diabetes. In fact, only 5% of people with diabetes mellitus have type 1 diabetes. Type 1 diabetes is caused by some cell damage of the beta cells of the pancreas. Many think due to an autoimmune disease where the body basically kills its own beta cells in the pancreas. The result is a reduction in the production of insulin. And the insulin, we know, is very important in helping sugar or glucose specifically to move into the cells. So if it can't move into the cell through the involvement of insulin, it stays in the blood, thus producing the common symptom called hyperglycemia or high blood sugars. Now, the genetic link is relatively weak, but it is there, 1 in 4 to 1 in 10 if both parents are diabetic. And the treatment is essentially a lifelong management of diet and insulin injections on a daily basis. The most common diagnosable characteristic of type 1 or type 2 diabetes is hyperglycemia. And these are the 4 characteristics, the 4 traits of hyperglycemia that are used in medicine. A random blood sugar greater or equal to 200 milligrams per deciliter. A blood glucose greater or equal to 126 milligrams after an 8-hour fast, or a blood glucose greater or equal to 200 milligrams after a 2-hour glucose tolerance test, or GTT. They also use the hemoglobin A1C in a value greater than 6.5% to indicate a long-standing hyperglycemia in the patient. The glucose tolerance test consists of actually taking 75 grams of glucose in the form of a drink, a sweetened drink, and then following the blood sugar levels, generally after a 3-hour period, but it can be used as more up to a 5-hour period as well. The diagnosis of prediabetes is pretty important because the prediabetic is also at high risk of heart disease and stroke. So the normal blood value that's monitored is a fasting blood glucose, and for a healthy individual that should be between 70 to 100 milligrams per deciliter. But for a person with prediabetes, 105 to 125 milligrams per deciliter, and this value, or this range, is used to diagnose prediabetes. It's also used as the glucose tolerance test, and this is called the postprandial plasma glucose, and this is when the glucose values are greater than or equal to 140 milligrams per deciliter, but less than 200 milligrams per deciliter, and this is after a glucose tolerance test. The symptoms of hyperglycemia that are found in both type 1 and type 2 are polyuria, polydipsia, ketoacidosis, ketonuria, and glycosuria. So polyuria simply means frequent urination. Polydipsia means increased thirst. Ketoacidosis means the ketones are rising enough in the blood that it's creating acidosis. Ketonuria means that the ketones are now found in the urine, and glycosuria means that there's glucose in the urine. The impact of the hyperglycemia, or the high blood sugars, on the biological system is complex and devastating. In fact, 60 to 70% of diabetics suffer from mild to severe nervous system damage called neuropathies. 60% of non-traumatic lower limb amputations are tied to diabetes, and 44% of new cases of kidney disease are linked to diabetes. At this stage, you should have already begun listening to the documentary A Diabetic Nation, an American Tragedy. The access code inside the cover of your textbook will give you access to this particular documentary free of charge at the publisher's website. The documentary is a 90-minute investigation into the prevalence, the causes, and also the treatments of this particular disease. So it's important to study the documentary as you would a textbook. The study guide is available in the appropriate folder online. So please take the time to prepare with the study guide, answering all the questions, preferably typing them in as you go. Here are a few questions that might be helpful that are found in the study guide. Explain why abdominal fat in obesity increases the risk of developing type 2 diabetes according to the documentary. Know this mechanism well. Dr. Stephen Ponder, a pediatric endocrinologist from Corpus Christi, Texas, describes many symptoms among diabetic children living in this area. Be able to identify these symptoms and explain them. There are 20 or so concept questions in all that you need to prepare for. Prepare well. As we think about the causes of type 2 diabetes, the literature draws our attention to these particular phenomena. First, the fetal maternal explanation, the thrifty genotype, the nutritional transition, that is, moving from a scarcity diet to an abundant diet of calories, social attribution and cultural perceptions of obesity, and globalization. The outline of these causes is found in the textbook, but the documentary goes into more detail. Allow me, for the moment, to explain these phenomena briefly. First, the fetal and maternal explanation. The fetal maternal explanation is related to an intimate understanding of the fetal and maternal relationship that exists during the period of fetal development. Everything the mother does will influence the fetus. So if the mother overeats, she produces extra insulin and she causes increased growth in the child. If she undereats, she eats, of course, less calories. This causes, of course, leads to a smaller baby. But the paradox also is that mothers that become obese through excessive eating can also not only produce large babies, but they can also produce small babies. There are indeed low birth weight infants, many indeed, that are born from obese women that eat excessively during the period of pregnancy. There's an intimate relationship that takes place here during this period of time. In the case of large babies that deposit a lot of fat from the extra eating that the mother goes through, many will recognize that the baby will be born sort of pre-diabetic, so with a propensity to become diabetic. In the case of low birth weight, it's very clearly understood that low birth weight infants have a tendency later on, near the end of adolescence, to start putting on weight as a result of their low birth weights in a means of compensation for a world now that has plenty of food. Epidemiologists now recognize that low birth weight infants later on have a tendency not only towards obesity, but chronic disease as well. This phenomenon is explained in the second part through the thrifty genotype. There's a thrifty genotype that develops as a result over periods of time. Sometimes they think along the lines of hundreds of years, perhaps thousands of years, where the genotype in particular ends up increasing the synthesis of fat during periods of plenty so that they may theoretically survive the periods of famine. So, in a world of plenty of food, low birth weight infants, for instance, will have a tendency to synthesize fat and unfortunately become obese. This tends to occur later in life. The nutrition transition is typical of migrant populations or immigrant populations that move in to the country from third world countries. So they move from third world countries into the United States, and they move from a diet of scarcity to an environment of abundant calories and low physical activity. And as a result of that, they put on a lot of weight and develop the diabetes very quickly. The other problem, of course, is the social attribution and cultural perceptions of obesity. Oftentimes, the obese are not really recognized as problematic, but simply culturally acceptable because of the abundance of the obesity in the society. So they don't necessarily stick out, and they're not necessarily directed to try to lose weight because they really sort of are blending into the culture. Globalization, on the other hand, has really allowed a distribution of a lot of processed food, a lot of meats and dairy and oils across the world into developing countries. And as a result of this, prices have gone down, and this result in easy access to cheap, high caloric density foods that end up leading to obesity and type 2 diabetes. Another cause of the diabetes, of course, ties into the highly processed nature of the diet, and one of the features of this processed diet is high fructose intake. And there's a theory that this abundance of fructose in the diet now leads to steatosis, or what we would call fatty liver. The review of the literature concludes that high dietary fructose intake positively correlates with increased dyslipidemia, that means a bad lipid profile that indicates heart disease, insulin resistance, and hypertension. Metabolism of fructose occurs, and we talk about fructose here because the sugars that are used have a higher percentage of fructose. So the metabolism of fructose occurs primarily in the liver, and high fructose flux leads to enhanced hepatic triglycerides, which are really fats, accumulation, leading to hepatic steatosis and an increased pro-inflammatory cytokine expression. This fatty accumulation in the liver can be explained biochemically. When we look at the pathway, fructose 1-phosphate can be metabolized into dihydroxyacetone phosphate and glyceraldehydes. At this entry point, as this entry point is distal to the glycolysis rate limiting enzyme phosphofructokinase 1, unlike glucose, fructose can serve as a relatively unregulated source of acetyl-CoA, and it's this acetyl-CoA that becomes the primary starting point for fat synthesis. This slide is a biochemical representation of what essentially we're talking about. Visually, what we see here is fructose being broken down to fructose 1-phosphate, and then through the action of fructose 1-phosphate aldolase, it is broken into glyceraldehyde and into DHAP, which is dihydroxyacetone phosphate. The dihydroxyacetone phosphate as well as the glyceraldehyde lead to glyceraldehyde 3-phosphate. What's interesting is the glyceraldehyde 3-phosphate is a common metabolite in the glycolytic cycle, and you can see by the red arrow how it is situated. Glyceraldehyde phosphate is the metabolite situated above the eventual production of pyruvate, which is identified down below on the right. Here we get to see the glycolytic cycle up close. So we see pyruvate right here. And we see that from pyruvate to acyl-CoA is a critical step because it's acyl-CoA that becomes the source, if you will, of fat synthesis. So from the previous slide, we saw fructose move to glyceraldehyde 3-phosphate, which is on this slide somewhere between glucose 6 and pyruvate, and then moving ultimately to pyruvate, and then to acyl-CoA, which then precedes the formation, as you can see with the big yellow arrow, the formation of fat. Coming back to the previous slide, you can see along the pathway with the red arrow that PFK, phosphofructokinase, is a critical step, and we call it a rate-limiting step. And it basically means that it downregulates or regulates the flow of metabolites down the glycolytic cycle. But notice here how glyceraldehyde 3-phosphate comes in along this glycolytic cycle under the PFK. So what this means is that the PFK is not being able to regulate the influx of fructose because the byproduct is glyceraldehyde 3-phosphate, and it's a metabolite that is under or below the phosphofructokinase, if you will, which is the rate-limiting enzyme. So this basically means that from glyceraldehyde all the way down to pyruvate, we have an unregulated flow of metabolites leading towards the production of fat. And this becomes the problem in terms of an accentuated synthesis of fat with products that are high in fructose, notably high fructose corn syrup. So the end product is not just an overproduction of fat, but it's an overproduction of fat in the liver, leading to fatty liver. There are three strategies for the treatment of type 2 diabetes that a healthcare provider needs to consider. First, the modification of the diet so that it's consistent with healthy eating guidelines, that it respects the macronutrient range recommendations, and so these hold true. And then the second is increasing physical activity, following the federal activity guidelines for Americans. Also, consistent with these guidelines, we have the Scholler study that shows that we need to expend 11 to 12 calories per kilogram per day from exercise. This works out to be consistent with the physical activity guidelines of 300 minutes per week. And then we have the National Weight Control Registry that documents that on average, people who are successful at maintaining their weight after diet expend 2,682 calories per week in exercise. And then, of course, the third is to lose weight. Long-term goals should be focused on losing weight as opposed to short-term quick weight losses, which invariably lead to weight regain. So in practical terms, let's see what these equations translate into. So take out your calculator and let's do a few calculations. Let's begin with the Federal Physical Activity Guidelines of doing moderately intense activity of 300 minutes per week. Let's use, for instance, running at 0.072 calories per pound per minute. So if a person is doing 300 minutes while running a week, while expending 0.072 calories per minute, we can say that they're expending 300 times 0.072, and that would be 21.6 calories per pound. And if we use someone who's 200 pounds, that's multiplied by 200, and we get 4,320 calories expended per week. If we take a look at Scholar's recommendation of 11 to 12 calories per kilogram per day expended in exercise, if we take the same individual who weighs 200 pounds, we can see what recommendations Scholar has for them. So 200 pounds times 0.454, so that's 90.8 kilograms. And if we take 12 calories per kilogram per day, we multiply that by 12, and we get 1,090 kilocalories per day. And so if we multiply that by 7, we get for the same individual 7,627 calories. Now, Scholar's study was done using doubly labeled water in free-living individuals, and it actually recognized as a gold standard in measurement for what individuals need to maintain a healthy body weight. And this amount, of course, is exceedingly high and very difficult to achieve. And it reveals a lot in terms of how we need to institute specific exercise protocols in individuals' lives. And it really comes down to integrating daily activities that are meaningful and that people need to do in order to move on with their day. For instance, like walking to work, for example, if that were something that that could be done. And this would ensure a regular expenditure. And this is basically what Scholar's conclusions are. The other guideline that's followed as an ideal is the National Weight Control Registry. And this registry it consists of individuals who have successfully maintained their weight loss, and they burn on average 2,682 calories per week. So this gives another perspective, usually in walking or in running slowly. But essentially, this is the amount that's being burned. So you can see that the guidelines vary significantly. The Federal Physical Activity Guidelines of 300 minutes of moderate intensity leads to 4,320 calories a week for a 200-pound individual that's running. It leads to 7,627 calories in an individual whose body weight is 200 pounds. And the other is that we should be burning about 2,700 calories a week in order to be successful at weight management. So it leaves you a little bit of some variability here in understanding the importance of energy expenditure in exercise. Perhaps one of the reasons why our clients or our patients are not successful in decreasing their body weight or even maintaining their body weight because of exercise is that we just simply don't expend enough energy on a weekly basis. We're not regular with our exercise. We don't exercise long enough. And it comes right down to, well, can we? At the end of a day, of long work hours, coming back and going to the gym. We could do it with some motivation, maybe 2, 3 times a week, but ultimately Scholler's study demonstrates that actually this physical activity needs to be more completely integrated within our daily lives. I like giving as an example purposeful walking. For instance, there are patients of mine who work probably about 3 miles from home, and I encourage them, especially when the weather is not inclement, to walk to and from work. Let's take a look at the energy expenditure that would be occurring on a 5 day a week work week. First, walking at 3 miles an hour expends approximately 0.025 calories per pound per minute. So say your client is 200 pounds and needs to lose some weight. Let's take a look at exactly what kind of energy expenditure we're looking at. So 0.025 times 200 pounds, and we find that this person is actually burning 5 calories per minute. Walking at a speed of 3 miles per hour, it would take literally an hour to walk to work. So that 5 calories per minute times 60 minutes would be 300 calories expended just to walk to work. And then walking back from work would be another 300 calories. So that would be 600 calories per day. If this person works 5 days a week, then that would be 600 calories a day times 6, or times 5 rather. So 600 calories times 5, and that would give you 3,000 calories burnt per week in a consistent fashion. This is purposeful walking. Not walking on a treadmill, but walking because you need to get to work, and walking back because you need to get home. And this would be 3,000 calories above and beyond this person's normal caloric requirement. Now, muscle strengthening exercises, going to the gym for strengthening, and some aerobics in addition to this, maybe 3 times a week, would easily bring this person's weekly expenditure far beyond 4,000 calories. So now we're getting closer to the goal. So now let's proceed in a systematic approach in, first of all, determining the patient's total energy expenditure goal. So we're going to use the Garrier equation. And in this case, you're going to use table 2.5 in your textbook for the activity level appropriate for the Garrier equation. So again, to remind students that it's important to have a cheat sheet that has these particular equations on them, and this allows you then to expeditiously complete the equation and derive a total energy expenditure for your patient rather quickly. So it's important, in order to integrate exercise into the lives of individuals, that a public health strategy be taken. For instance, health clinics could possibly set up or forge relationships with fitness centers, radio stations, churches, and schools, all with the purpose of immersing the public into the thinking and attitude change towards exercise, so that work and play and daily living have integrated exercise, integrated purposeful exercise, if you will. An example would be walking to the grocery store to pick up groceries, have the grocery store ship the food back to the house. This is one way of also having sort of a purposeful exercise. You could do it in groups. There's really all kinds of different approaches that can foster this positive attitude in a community towards purposeful exercise. Now, the history of public health initiatives is not all that rosy when we look at it collectively. Point in fact, the Binestar school-based program, which involved 27 elementary schools in Texas, and the goal, of course, was to increase physical activity among the students. Now, the findings were that there was indeed an increase in physical activity, but also an increase in caloric intake, and this caloric intake did not really influence blood sugars, nor did the exercise influence blood sugars. And that, of course, was the goal. And of course, at the end of the day, students ended up with a greater body mass index. Now, the main finding from several studies, several public health studies, was this: eating habits are really difficult to change, especially in the youth. There's a strong addiction to pleasurably tasting foods. This habituation to foods are usually high in sugar, salt, and fat, and it makes it very difficult once students are introduced to this to basically move away from it because of the addictive nature of these particular foods, these particular processed foods. The public health initiatives that appear to give some hope to the resolution of diabetes and obesity is first prenatal nutrition initiatives, teaching women how to eat properly to ensure the proper growth of their babies. So there's this idea of the fetal maternal relationship that's very, very intricate and very intertwined with mother's health, and also consider also the long-term genetic or epigenetic altercations due to the thrifty genotype that may influence historically the particular ethnic background of an individual. So, of course, prenatal nutrition is very important. And then focus on breastfeeding, this idea of feeding proper nutrition for 6 months to 1 year. So, the most interesting and convincing studies indicate an improved health for the baby and the child leading into adolescence and early adulthood if breastfeeding lasts a minimum of 6 months. And finally, the third is to protect the children against the obesogenic environments that are arising everywhere with fast food and junk food prominence, the obesogenic environment influenced by marketing of food, of snacking, of cola drinking, and so forth. And we have to protect our youth against that, because once they become exposed to these highly addictive foods that are high in fat and salt and sugar, it becomes very difficult, as previous studies have indicated, to sway them away back to good eating habits. So now let's move to the end of the chapter and take a look at our first case study, a 32-year-old woman with hyperglycemia. So this is a 32-year-old female who presents with fatigue, hirsutism, polyuria, polydipsia, and numbness in her hands and feet. So it's important for the student now to look up these various characteristics, hirsutism, polyuria, and polydipsia, and become familiar with them. Her height is 5'5", and her current weight is 333 pounds, and her usual body weight is 357 pounds. So this is very typical, because as the person progresses into greater sickness and fatigue, there is a definite loss of appetite associated with hyperglycemia. So it is typical to see some body weight loss at the beginning. Her pertinent complaints are sleep apnea, joint pain, and lower back pain. Let's take a look at her medical assessment. So her blood pressure rather, is very high and will definitely need some drug therapy. She has hypertriglyceridemia. Her triglycerides are over 150 milligrams per deciliter. Her random blood sugar is 304 milligrams per deciliter, and it's over 200, which typifies really hyperglycemia. Let's see, she also has metabolic syndrome. Let's investigate why. We learned from chapter 4 that metabolic syndrome means that a patient should have 3 or more of the 5 risk factors. And here are the 5 risk factors: a fasting blood sugar greater than 110 milligrams per deciliter, HDL, high density lipoproteins, less than 40 for a man or less than 50 for a woman, Serum triglycerides greater or equal to 150 milligrams per deciliter, a waist circumference greater than 35 inches in a woman, and a blood pressure with a systolic value greater or equal to 130 and a diastolic greater or equal to 85. So let's see what are the characteristics of this patient. So let's take a look and see if she meets the requirements for metabolic syndrome. First, the patient's blood pressure at 189 over 98. And if we look at the requirements for metabolic syndrome, we can see that indeed the blood pressure systolic is greater than 130 and the diastolic is greater than 85. So definitely blood pressure meets the requirement. If we look at the triglycerides, they're greater than 150 milligrams per deciliter. And the blood sugar is a fasting blood sugar. So the fasting is definitely over 110 milligrams per deciliter. So therefore, she meets the requirements to be diagnosed as metabolic syndrome. Let's take a look at other characteristics about our patient. First of all, we should be able to calculate this patient's body mass index. So that's something students should have as part of their strategy because body composition assessment is very important. So body mass index, weight in kilograms divided by height in meters squared, gives us 55.5, suggests she is extremely obese. Her waist circumference is 65 inches, which is reflective of the abdominal fat, and it's definitely for her over 35 inches, which puts her, again, one of the factors for metabolic syndrome. What about her percent body fat? Well, detected by bioelectrical impedance, it's at 57%, so she's definitely over fat. At this point, I want to draw students back to table 3.1 in the obesity chapter in your textbook, and you'll notice that the recommended range for healthy fats in a woman is 20 to 35%. So at 57%, she is definitely over fat. Now let's look at the qualitative aspects of her diet and her lifestyle. She's a secretary who sits all day, so she's pretty sedentary. She has a long history of obesity starting at 10 years of age. We know as well that both her parents are class 2 obese. Sedentary lifestyle, very little physical activity even right from youth. So when we calculate her TEE, using her height and her age and her weight and a low physical activity, we get about 2,888 calories, which would be typical, of her requirements for energy in order to maintain her weight. If we look at table 5.2 in the textbook, we understand a little better something about the quality of her diet. Now, table 5.2 is essentially a food record, and you can see it indicates the type of food, the quantity, and the place, and possibly the time as well, where it was consumed. And this allows us to understand what she's actually consuming in quantities of energy and in nutrients. So what are the key nutrients that should be assessed? Well, the calories should be assessed, even though it's not a nutrient, and then carbohydrates, protein, and fat. This is very relevant because you want a good distribution here, and you want those carbohydrates to be complex and whole grain. You want also total sugar assessment to make sure that there's not a lot of sugar infringing into the carbohydrate requirement. And you want to look at sodium intake because it gives you an idea of the degree to which the diet is processed. Well, in reviewing table 5.2 for the food intake, we find that there's excessive soft drink consumption, which leads to over a pound a day of sugar, which explains her elevated triglycerides, her elevated insulin, and elevated sugar. Her fat intake represents 56.4% of her DRI calories, which should clearly cause total cholesterol and LDL cholesterol decline. So these are not good features. So what are the recommendations? First, a diet to stabilize her body weight and thus prevent further weight gain. Second, eliminate critical foods that are affecting her diet, and then introduce healthy food alternatives. So let's get a little more practical. So first we understand that we're going to stabilize her body weight and thus prevent further weight gain. This is important because we don't want to put this person immediately on a caloric restriction since they've been significantly overeating. We know by the textbook, if we look at the case study, that she's been consuming 5,241 calories and her requirement is really 2,888. So she's been over-consuming. So the goal here is to bring that overconsumption down to a stable level in which she gains no more weight. This helps her to familiarize herself with good eating habits. Now, to facilitate this, we're going to eliminate critical foods that are affecting her diabetes: the soft drinks, the donuts, and the cakes. Then we're going to introduce healthy food alternatives. We're going to experiment with fruits and vegetables, find out the ones that she likes, the ones she doesn't like, and then try to introduce those that she doesn't like one by providing adequate recipes that entice her to want to at least experiment with those vegetables. Provide with vegetable recipes that really taste good and look good. Also, provide fruit dessert recipes that are low in fat and low in sugar. Now, because we understand this patient have hyperglycemia, but also metabolic syndrome, we need to make some recommendations with respect to the kind of diet that she should be following. So her caloric recommendation is 2,888 calories. We want to calculate the quantity of nutrients that she should be consuming. First, coming back to Chapter 4, you have to understand that metabolic syndrome means she has increased risk of cardiovascular disease. So it would be appropriate to recommend the DASH diet. Could be the TLC diet as well. But as an example, we'll do the DASH diet. So based on the calories, we're looking to achieve 27% of calories coming from fat. For protein, we're looking at 18% of calories coming from protein. And then for carbohydrates, we want to achieve 55% of calories coming from carbohydrates. Saturated fat, we want to be less than or equal to 6% of DRI calories. And then for monounsaturated fats, we have to use a little bit what we learned at the beginning of the chapter and also at the beginning or in Chapter 4 specifically regarding monounsaturated fats. So healthy monounsaturated fats is 11% or greater all the way up to 20% of DRI calories. So we have some range here for monounsaturated fats. Polyunsaturated fats, the DASH diet recommends up to 10%, but overall we understand the range to be 5 to 10%. Now next, what do we do about sodium? A standard, not too difficult restriction would be less than 2,300 milligrams per day. The other would be 1,500 milligrams per day, which is seriously more restrictive and would require that the patient develop their knowledge about spices and other food ingredients that would enhance the taste of food. So after some time on a 2,888 calorie diet for weight maintenance, possibly 2-3 weeks, maybe a month, we recommend then a diet for weight loss. So the student now must determine the rate of weight loss, determine the daily caloric goal for that weight loss, determine the goal weight to achieve, and determine how long it will take to reach that goal. So here are some recommendations. We know that the recommendation for maintenance is 2,888, so that really is her requirements, but we're going to look at what we need to achieve for some weight loss. The recommendations is about a half a pound to a pound per week, no more than that, because excessive caloric restrictions invariably seem to lead to rebound weight gain. So we want to avoid that. So we're going to have a half a pound to a pound. So this means, in terms of a caloric daily requirement, in order to lose 1 pound, that would be 2,388 calories per day, or a 500 calorie a day restriction. If we want to reach a half a pound of weight loss per week, that would be 2,638 calories a week, or a day, sorry, and that would be a 250 calorie a day deficit. Next, let's determine the weight goal to achieve, we could probably aim for something like 292 pounds. To achieve this, you remember, you need to set an ideal body fat percent goal to achieve. Determine how long it'll take to reach that goal. So if you're looking at a half a pound a week, it'll take 19 months or 1.58 years. If you're looking to achieve 1 pound per week, then it'll take 41 weeks or 9.46 months to achieve that goal. The goal weight determination is established in this chapter. So go into the textbook and examine the calculations. In the second edition, it's page 136. We can see that the goal body fat that we want to achieve for this patient is 35%. So please follow the calculations and the reasoning here. And if you're still, haven't learned it exceedingly well in chapter 3, now's the time to basically reinvigorate your knowledge about determining goal weights. As part of your preparation for the assessment quiz, here's the blood biochemistry markers that you need to know for diabetes, or the diagnosis of diabetes. The normal fasting blood glucose, that should be 80 to 100 milligrams per deciliter. Pre-diabetes blood glucose, 100 to 125 milligrams per deciliter. If you want to diagnose diabetes in the patient, then you're looking at a blood sugar of equal to or greater than 126 milligrams per deciliter. The normal hemoglobin A1C is less than 5.7, but for prediabetes, hemoglobin A is between 5.7 to 6.4. And you can diagnose diabetes using hemoglobin A1C, which is a sign of the persistence, if you will, of the high blood sugars. This occurs with an A1C of equal to or greater than 6.5%. So at this point of the presentation, I'd like you to memorize this table so you know it cold and be able to use it in some critical case studies. So let's do a training quiz on diabetes and on weight loss. Now, it's important to remember that the grades or the results of these quizzes do not go towards your final grade. All right, in this question, we have a 24-year-old female who has a body mass index of 44.9, a height of 5 feet 6 inches. She has a body fat percent of 43%. Her goal is to get down to a body fat of 30%. I want you to determine her goal weight and the total energy expenditure she needs for weight maintenance using the Mifflin equation, and I'm giving you the activity factor here just to expedite the calculation of 1.2. Remember that the goal in using the Mifflin equation, because I encourage you to memorize it, is to complete an REE and a TEE using the Mifflin equation within 30 to 45 seconds. So if you're not that proficient yet, I encourage you to practice the Mifflin equation until you can resolve it within that 30-second to 45-second range. Now, the first thing to resolve is, what is this patient's body weight? You can determine this, of course, with the body mass index, because the body mass index is equal to kg, the weight in kilograms, divided by meters square. So we know the height, we can change that into meters square. We know the body mass index, it's 44.9. That leaves us with one variable, the weight, and so we can easily determine this. Indeed, kg then is equal to 44.9 times the height in meters square, or 1.68 square. So kg is equal to 44.9 times 2.82. So kg, the body weight, would be equal to 126.62 kilograms. Once the body weight is established, now you can establish the REE, and using the activity factor, the TEE. Let's pause here and do your calculation. The Mifflin equation multiplied by the activity factor should have given you 2439. So we have two options, A or B. The goal weight then should have given you 227 pounds. So the correct answer, B. Here's another case. A patient presents with blood sugars of 150 milligrams per deciliter, blood pressure of 132/93, triglycerides of 165 milligrams per deciliter, HDLs equal to 52 milligrams per deciliter, an insulin value of 4.7. What do you conclude from looking at this patient profile? At this stage, this is where knowing your cutoffs and your values are very important. So the correct answer is this patient is only metabolic syndrome. Because in this case, they're not diabetic. The blood sugar values indicate pre-diabetes. There's definitely hypertension. Triglycerides, yes. HDLs are great. Insulin is under 5, so it's actually non-hyperinsulinemic. So you should be able then to adequately conclude that the patient is only metabolic syndrome. Next question. It's been proposed that high fructose corn syrup may be responsible for a rise in obesity and cardiovascular disease risks. Identify the likely biochemical cause. Pause here and determine your answer. So you should come up with the right answer, which is C. Fructose in high concentrations can freely flow towards the abundant synthesis of glyceraldehyde 3-phosphate and then to acyl-CoA, unhindered by the rate-limiting enzyme PFK phosphofructokinase, therefore leading to an unregulated fat synthesis, which leads to steatosis and cytokine productions. Next question. Identify below the fasting blood glucose that would be considered pre-diabetic. Pause here, select your right answer. The correct answer is D, because the blood sugars are between 100 and 125 milligrams per deciliter. This is found on page 126 in your textbook. Next question. Identify the fasting blood glucose cutoff indicative of diabetes or hyperglycemia. Pause here and select your answer. The correct answer should be C, equal to or greater than 126 milligrams per deciliter. Final question. Identify the fasting A1C cutoff indicative of diabetes. Pause here, select your answer. The correct answer is C, when the hemoglobin A1C is equal to or greater than 6.5%. This is the end for the lecture on diabetes, and I encourage students to train themselves by practicing with similar case studies in order to refine their ability to correctly diagnose using critical thinking, and of course the memorization of these cutoffs help tremendously in that form of critical thinking.